And I really appreciate that opportunity because we were able to start the conversation at a lot of different levels. And I was privileged that my friend Ron Short invited me to come and speak because I was able to talk about it and be a part of changing the paradigm into something that's really about being a doctor of dentistry, not a technician. And
it was a real privilege, Mike, for me to be there in that meeting with you, to hear that decision being made.
Yeah, and it was good that I was there. In fact, it was nice because the executive director of the Dental Association, or the Board of Dentistry, called me and said, we really need you there. And it was good that I was there because the representative from the Dental Association was saying, well, yeah, but we don't know about this, and is it safe, and all that kind of stuff. And I was able to say, you know, very frankly, I told the story of Dr. Edwin Lowe, who spoke at the University of Oregon Dental School one night, that a lot of us had a privilege to be there, a full room full of people, including faculty at the dental school. And one of the faculty members of the dental school said, well, how do we know if this is safe? And Dr. Lowe paused like, I don't understand the question. Almost like, this is a foolish question. He says, we've done hundreds of thousands of children over decades without one adverse outcome. We've used silver diamine fluoride for decades over hundreds of thousands of children, and there's not one reported adverse outcome. And so the nice thing about that question was it was actually out there and recorded amongst a group of people. And it's used appropriately in the appropriate place. It's a very, very safe product. And what it does is it allows us to get the disease under control. And we're not here advocating we should not do fillings. What we're here is advocating that before you do fillings, you have to have the disease under control. And do you really need to fill certain types of fillings? Is it really wise use of resources to fill children's teeth that are going to be lost, that aren't in a place where when they smile it damages their self-worth, or potentially damages their self-worth? Is it, do you really want to fill root decay in elderly people whose disease is out of control? Because when you put a burr to the root, you end up in the pulp invariably. Then you got to do a root canal. You do a root canal on a tooth that's on a root decay, and the next thing you know is you try to fill it, put a crown, it breaks off the gum line, and it's a disaster. But you can actually stop the sensitivity, you can stop the decay, and they don't have to have anything. And you can do it right in their setting of where they're laying in bed or sitting in a chair or whatever. You need a headlamp and a tongue blade and a little applicator and a 2x2 to dry it off with.
So you can take the technology to the patient, which is an important part of this whole message.
And so that's part of what I talked about earlier, is how do we take the science, and what is the appropriate science, where should it be applied, and who should apply it? And so what we started looking at, medical managed care is really a piece. What it does, it gives us a tool when you got the result of the infection, which is the cavity. Well, is there a way we cannot get the cavity? So we started looking at, what do we do? Well, we learned in Klamath Falls that you can actually lower the amount of tooth decay by intervening with the mother and the child at an early age. Well, where does the mother show up? Well, the mother shows up in WIC. You know, the low-income women show up in WIC. So where's the place to take the science? What we've been doing is putting expanded function hygienists in the WIC setting and doing prevention. And very frankly, if you just give a pregnant mother and just have her paint fluoride toothpaste on her teeth every night and go to bed with it, you can lower the amount of infection by 20%. Up to 20%, I should say. Just by having them go to bed with fluoride toothpaste on their teeth. Well, if you do a prophy on them, a cleaning on them, where you get their gums and the gums where they're not infected, and I don't really think you need to do that, but if you do, because we have the tools to do that, you can lower another percentage. And if you can teach them how to brush and floss, you can lower it some more. And very frankly, if you could paint silver diamine fluoride on their cavities, it might lower it some more. But because they're pregnant, you wonder about giving them chemicals, and so you have that debate. I suspect it doesn't make any difference, but we don't know yet. I don't know. I don't know if we know yet, but I haven't learned. Maybe we do know yet, and I don't know about it. But
a lot of scientists are studying now. They're attending to this subject.
And what happens if you put a little fluoride in? It's okay to put fluoride in their mouth, but what happens if you put a little silver on their tooth? And very frankly, I think if you just painted their cavities with silver diamine fluoride, their kids would have a lot less decay. And what we proved in Klamath Falls is if you do interventions, any kind of intervention that lowers the disease load in the mother, her child has less decay, up to 50%. And it was pretty rudimentary what we did. And it was kind of hit and miss, scattered, but what we did is we had a lot less decay. And that's what's important. You know, we could lower the amount of tooth decay by just intervening with the mother and the child. So the next thing you do is once the mother has a child, where does she show up? Well, what I learned from talking to my pediatric buddies is that I said, well, how many well baby visits can you get by age 3 if everybody got what they needed? And they said 12. And I said, 12? I only need 4. And so then I said, well, the problem with fluoride varnish is, and we have a program now where they'll pay pediatricians to do fluoride varnishes. The problem with fluoride varnish is, what is it, 27%, 30% reduction if you do varnish? We still got 70% of the cavities. And so you lowered to 30%, that's great, but you still got 70%. Well, what we found was through the literature and working with Dr. Milgram is that if you put betadine on the teeth as well as varnish, you can lower it 75%. So now you can lower the disease 75%. So now you only got 20%, 25% to deal with. And we know if you threw in some nutrition and you got rid of the sugar, you could probably get it to 100%. And who knows what combination is the right combination? That's yet to be determined and yet to be discovered. But so we got involved with doing a betadine and varnish in combinations. You wipe the teeth off, put on the betadine, you wipe it off, you put the varnish on, and it could be done. And where should it be done? It could be done in the pediatrician's office or the primary care dentist's office. And if it was, then what we're looking at is, how do we pay? How do we take some of our dental dollars and pay the pediatricians and the primary care to do what we need them to do so that at age 3, we don't have to fix our teeth? And so what we've been doing is looking for those pediatricians that are willing to work with us. And we've got some, I don't call them studies, but we've got some small case studies where we're actually working with the pediatricians. You know what the pediatricians tell us why they won't do it? It doesn't fit into their workflow. So what we've done is we've embedded an expanded function hygienist into a pediatrician's office to see how we can help them change the workflow. And then how can we pay them so much per patient per month to do these interventions for us. And then what we want them to do is do the interventions, and then we want them to look at their teeth at age 2 when they come in to see if they got any brown lesions. If they got brown lesions, then we can take silver, antimicrobials like silver, paint on that brown lesion. Very frankly, they could do it. They could do it done right in a pediatrician's office. They don't need to be done at the dental office, though. I mean, they really don't need to be. But then we can get them to 3 years old with no decay, and then any dentist can see them. Any dentist can see a 3-year-old with no decay. And if they do see a brown lesion, because where's the next place they show up? It's early Head Start. Well, let's look in their mouth at early Head Start. Where do they show up next? They show up at Head Start. Then they show up in kindergarten, first grade, second grade, third grade. But in the interim, we want the dentist to be able to look in their mouth, because there's a lot of things the dentist can look at at least once a year. And the main key point is, let's do a risk assessment on the mother and the child. And let's do risk assessments. If we know those kids are at risk, and one of the things we're working on is kids that are not at risk, if they are low risk, all they need is fluoride toothpaste twice a day and go to the dentist once a year. That's it. Probably don't even need to go to the dentist once a year, but very frankly, we think they need to go to the dentist once a year because there's a lot of other stuff that the dentist looks for other than just cavities. They look for periodontal disease, they look for cancer, they look for other kinds of infections that can show up in the mouth. And so if we have a system to prevent the disease from mother to child, because that's when the infection is passed, and very frankly, if the child isn't infected in the first 6 months of their life and their immune system kicks in before they're and the bacteria there that's bad's not there, guess what? They don't get the disease. They don't get the disease because their immune system, unless their immune system gets overwhelmed some way, they don't get the disease. Their immune system actually fights the disease. So then you've truly prevented the disease. Once you're infected, you can control it and prevent the ravages of the disease, but you can't prevent the disease. So most of us have to brush and floss, eat right, do those kinds of things to maintain our disease, use fluoride, those kinds of things. I suspect, and Dr. Duffin's done a lot of work on this, I suspect when they have the silver on the cavity, that in itself changes the microflora. And if it's present there, I suspect that we change. I don't know if we change it forever or we just change it for a while. And that's one of the things that we'll probably look at with time. But what we're finding is kids that are painted with minor microbials like silver on the cavity, is it prevents future cavities. What we found when we were doing with the stuff we had to do for the FDA, we had to paint adult teeth, 28 teeth with silver diamine fluoride, and then measure how much silver and fluoride ended up in the saliva, urine, and blood over 7 days. And what we found is 70% of the silver was impregnated in the tooth. It wasn't excreted. I mean, 90%. So what it tells me is it's absorbed in the crown of the tooth, and that silver in the crown of the tooth would then therefore prevent the formation of biofilm. And in that case, you wouldn't get disease because you got to have biofilm to get the disease. What you find is healthier gingiva, less periodontal disease, and less decay. And so that remains to be looked at too. That's just an observation of what we did. And
so, Mike, tell me a little bit about what you see our oral health system looking like 10 years from now. Now that we've opened the door, congratulations, and we have some new technologies and ideas.
In my travels, in this adventure in life, I have had the opportunity to go a lot of places. And one of them was I was invited to speak at the National Association of Medicaid Dental Programs in the state dental programs. And at that meeting, what I told them was, you don't need our drill. You need our knowledge of how to prevent the drill. And I outlined a program that I've just talked about. What I see is this basic bottom line. What I told them is you don't blame the pediatric, because I made the comment that we don't need to be sending kids to the hospital to fry their brains. Well, the American Academy of Pediatric Dentistry was there, and I mean to tell you, at the end of the meeting, they were there, and they were all over me. And so the next morning, I got the opportunity to talk about it, and I said, I want to apologize for if I offended a pediatric dentist. But it isn't a pediatric dentist's fault, because you, the community, are giving them so much disease that they don't have any other solution. They didn't have any other tools. And so up until now, they don't have any other tools. And so don't blame them. You, the community, has to look at how come are we allowing this infection to be passed from mother to child, and why are we not doing something about it? And why are we blaming the dentist? Why are we beating up on the dentist saying we need you to more access to care? Because it's not going to work. So I said that what I see in the future is the community understanding what's going on and reorganizing itself so that we get out of the silos. We start realizing that we have people with behaviors that are getting in the way of them having the triple aim, basically a better experience, better care, better health at a better cost. Because in Central Oregon, where I live, 5% of the people spend 50% of the money in Medicaid. So 2,500 people spend $125 million. 10% of the people spend 70% of the money, and 20% of the people spend 80% of the money. So we have 10,000 people spend $200 million. Well, how do we manage? It used to be that mental health, behavioral health was, we were going to get people in, we were going to give them counseling, and because of their childhood wounds or whatever happened to them, we would get them to understand that, and we'd get them to be able to change and become a more functioning citizen. The problem with that is it didn't work. And so then they started looking, the behavioral health people started lobbying and railing against the healthcare system, saying that the system's wrong. If you just treated them better, you had more motivational intermediate and all that kind of stuff, then the people then could access care. Well, that didn't work either. So where we are today is how do we help manage those people's behavior so we get a better outcome? They get a better experience and we spend less money. So where we're at today is how do we manage the people that have chronic illnesses that are impacting the overall spend, and how do we help them have a better experience, how to help them get healthier, and then how do it cost us less money? And that's where we're at today. And so how does our community sit down and say, very frankly, there is no reason for anybody to have a cavity. There isn't. With what we know today, by and large, there's no reason to have a cavity if we applied the science in the appropriate place with the appropriate person. And we really had a system to do so, and we could pay for it in a way that the system was rewarded for doing so. So I see the future being is if you can help people grow up with no decay, no cavities, no periodontal disease, you should get paid more. Well, we're in that throes. And one half of CMS the Center for Medicaid and Medicare Services, says Oregon used global budgeting. The other half says, well, we gotta do it actuarially because we gotta know how much work you're doing. In fact, Obama's new health care, 645 pages of the new Medicaid, wants 85% of the money to be spent on care. Well, there's no way you can spend 85% of the money on care unless you do procedures. So there's a real disconnect between, and it really comes down to how we know they're going to be doing enough work. How much should we pay them for the work that they do? You know, we know that the healthcare system is gobbling up more and more and more of the gross national production. So what's enough? And then how do we reallocate the money within that? And how do we do it without disrupting the system while we're doing it so we don't have anything? So we put people out of business because people go bankrupt, all that kind of stuff. And so that's where we're at today. So,
well, Mike, I think you've been a real leader, a trailblazer in helping our profession migrate into the future. And I think the future is going to be about being doctors, not technicians, as you said, being part of the healthcare team and moving people toward health as an outcome that we all desire.
If you want to know what some of the barriers are, we could talk about barriers. Barriers are, the barriers we have today are really frankly, like Albert Einstein said, insanity is doing the same thing over and over again, expecting different results. And the resistance to change that we have. Now, it's good to question, but when you question and you come up with a better solution, you have to let go of the past. And Don Berwick said, the remaining obstacles to accomplishing the triple aim are not technical, they're political. So how does the United States reorganize its belief system about healthcare and allow us to do things that produce better results? And that's where we're at today. And that's the biggest resistance we've had, is we were labeled with, you guys are not doing enough work. You're not fixing enough teeth. Well, what we say is if you're fixing teeth in the presence of an out of control infection, that maybe you're doing something unethical and you ought to look at the disease. Like I said earlier, if dentistry is in charge of iron lungs, we'd have better iron lungs. And what we ought to do is put the doctors in charge of why do we have an out of control infection and work on that end. This whole balance between the community and the individual that we're struggling with in the United States today is really the issue. We have a system that honors strong individualism. Pull yourself up by your bootstraps. Work your way up. Everybody's responsible for themselves. Well, what about those folks in our society that are victims or have been victimized? And what do we do in our system? How do we stand by in our system, in our society, and watch bad outcomes? Where people suffer the ravages of tooth decay and we don't do anything about it. We let the homeless lay on the street and die. And we don't. This is America. We're struggling with how do we get to be individuals and be independent, but yes, be interdependent and have everybody has the opportunity to be healthier and have a better life. And that's
seems to me that dentists are trained to fix teeth, and what we've been engaged in is trying to improve the oral health of a person and convey that into a community program.
Yeah, the community. The one thing about the coordinated care organization is the community is in charge. The community. In fact, they organize the providers around the table of their board of directors so that all the community members, the community and all the different providers sat around the table. And so the community is in charge. Well, if the community is in charge, then the community needs to step back and say, maybe what we're doing is not working. And what we've done is they rely upon the experts. Well, the experts have a vested interest, in perpetuating the past because that's what they know. So the community is going to have to sort out what really is what it really should we be doing, and what should we let go of. Problem with it is the community relies upon the experts. The biggest expert being the hospital, because they have the resources and the talent and the people that have the knowledge. And so somebody has to be outside of the community that says, no, we can't keep doing the same thing, because if we keep doing the same thing over and over again, we'll get the same results. And so it's a pretty complex process. So you have the government overseeing the community, allowing the community to guide the community to something better. And you do that by looking for better outcomes and holding them to better outcomes. And that's what the Oregon experience, I could talk about the Oregon experience. Oregon had $1 billion hole in its budget. Didn't have any money to fill it. So Kitzhaber told the Obama administration, we will participate in the Affordable Care Act, and we'll promise you that we'll bend the cost curve and produce better outcomes if you'll pre-fund us $1.9 billion over 5 years. And if we can't make it, then we'll pay it back. And then he implemented this our version of Accountable Care Organization, which is a coordinated care organization, and we turned it over to 16 different community groups, and we're in the process of that experiment. And very frankly, it's working. 2 years in, it's working. And we're actually bending the cost curve. And they actually, over 10 years, will have saved the federal government $1.9 billion. So we would have been we would have given better health, better care, better outcomes for less money. So we've bent the cost curve. What we promised to do is bend the increase by 40%, rather than 5.4% a year, it'd be 3.4. And very frankly, actuarially, it's coming out that way. And so we're in the middle of that experiment. Lots of resistance to it. Oregon's probably one of the few places in the country that it could happen. Everything lined up, and here we are. It's got its issues and its struggles, but it's, I think, working.
Well, congratulations, Mike, for being an important part of that process. It's been an honor to be your friend and colleague over the past 20 years. And let's keep going.
Yeah, we're just getting started. We're just scratching the surface, and there's lots to do. And a big piece of it is electronics. You got to have a system to support what you're doing, because you got to get at the data. And you asked me about the future. Part of the future is, how do we get at the data that we're doing to see what it's doing, so we can see what's working and not working. And we have to do this in a way, we just can't do the same thing anymore in the future. The nice thing about having computers and being able to have databases is that we can then begin to look at what's happening. Before it was all a gut feel, and we think, and it was so laborious to get at the data. So one of the things we'll be able to do is because electronic, is begin to look at things in a real way. And so we have to develop our databases in a way that we collect up the data. One of the fallacies for dentistry is they don't have a diagnostic code. We don't have diagnosis codes. And so we don't know if you fix a front tooth, it's because it's chipped from trauma, whether it's from a cavity, from disease, or whether the person just wants the tooth to look better because of cosmetics. We don't know, because there's no diagnosis code. All we know is we fixed the front tooth. And so we have to have a system to where if we fix a front tooth, we can put down it was because of diagnosis of infectious disease, or it was from the fact that it was trauma to the tooth, or the fact that it was cosmetic. We have to have that, and it's coming. And there's been some systems developed that we're looking at, and I know we're looking at we're trying to leverage we use the Dentrix Enterprise system. We're trying to leverage them into giving us diagnosis codes. And the problem is, which system do you use? And Harvard University has developed a pretty good system that we're looking at, and hopefully over the next couple, 3 years, we can have diagnosis codes so we can really get into it.
Well, congratulations.
One more thing is an issue.
Okay, go for it.
One more thing is an issue is the fact that we have 6 different dental softwares. How do they talk to each other? We have 5 different medical softwares. How do they talk to each other, and how do they talk to us? And then we have, I don't know how many behavioral health systems, and how do they talk to each other, and how do they talk to medical, and how they talk to us? And then you have the hospitals and their systems. How do they talk to each other? And so what we have is all these proprietary systems that we'll be trying to hang on to make money off of, and get in the way of us being able to get at the data. And so one of the things that we've been developing is a software system, a clearinghouse, so to speak. We already have it where all dental softwares can talk to each other. We're now starting to figure out how we can talk to medical systems. And the first one we're working on is there's a whole system that the emergency rooms now use, and we're figuring out how we connect to that. So we can come into work tomorrow morning, we can get in the system, saw who's in our system, went to the hospital, and appropriately, then we can then begin to case manage that. How do we get out on the field and we do a risk assessment and a screening. How do we get that information into the software so that it goes to our case manage, so we can case manage? It also goes to the primary care physician so that he knows, and so we're all working together. And so a big piece of it is we're working on that, and we're pretty close to having that done.
Congratulations, like going from the telegraph to the telephone. Well then.
And you got to remember that the only reason we're able to do this is because we fund it in a different way. We fund it in a different way. We fund it in a way that we can use the resources in the most appropriate way, and we can develop the systems in the most appropriate way. And we don't have to go ask for grants. Main reason we get grants is because we want to do research. We don't have to go get grants to change a new system because, very frankly, we have the money in a way where we can reallocate it.
So most dentists think the word capitation is a bad word. Do you have a different interpretation of that?
Well, I look at it for example, I had the opportunity to speak to the Ada County Dental Society in Boise. Ada County is where Boise is, where most of the people, most of the dentists live, most of the people in Idaho live. And they came and wanted me to talk about managed care, and they were all complaining, oh, they don't pay enough money in the Medicaid, and I said, wait a minute, time out. The state of Idaho is asking us to take care of 163,000 people, manage their oral health, and they want to pay us $40 million. They didn't ask us how many fillings we're going to do, how many crowns we're going to do, how many bridges we're going to do, whether they had to have perfect margins. What they want us to do is manage the population so they don't have to hurt, they don't have to use the rest of the system inappropriate, they can smile, they can be happy, and they can have better oral health. I said, I'm going to take the $40 million because I think we can do this. And so it's like, we got to look at it. How do we group together in a way where we, the profession, can manage the population better when we can do it in a way that makes sense to all of us professionally? And that's, I think the future is, I don't think the payors want to deal with individual dentists. They want to deal with a group of accountable dentists that are willing to step up to the plate and work with them to give the triple aim. And if you're a dentist who isn't interested in that method, then it's okay. You're just going to have to realize that the government-funded programs going into the future, and I believe the big corporations, if the government-funded programs actually do better, I think the big corporations are all going to be saying, wait a minute now, I think there's a different way. And if you're not involved with a group of accountable doctors, and I think those good doctors are providers, are hospitals, physicians, specialists, behavioral health people, oral health people, are all in this together, working in a way that allows us to produce better outcomes. We lay down, like Don Berwick said, we all have to learn how to give a little and compromise for this to work. All right.
Bravo! Thank you.